Good morning. I'm Kenny McKinley, and I'm junior faculty in emergency medicine and a clinician scientist with research that focuses on predictive analytics as well as sickle cell clinical research. As I became more involved in sickle cell research over the last year, I've had the opportunity to work with and learn from nursing research and education leadership in the emergency department, including the Teresas, both our director, Teresa Schultz, and Teresa Weber.
And I'm Teresa Weber, the Psychiatric Clinical Program Coordinator in the Emergency Department. In this role, I've had the chance to sink my teeth into quality and safety projects, which have been academically productive, including posters and 2 publications where Kenny and I are co-authors. These experiences served as a springboard for me to take on the leadership role for the EMTC Strategic Plan for Research and Advocacy.
Today, Teresa and I want to share our experiences with developing strategies to complete a phase 1 clinical trial in the emergency department during COVID. Increased healthcare needs have coincided with decreased clinical and space resources during the COVID-19 pandemic to create unprecedented challenges for clinical trials that occur in acute care settings. As many as 80% of clinical trials have had delayed starts or not started at all due to pandemic-related factors, including decisions by stakeholders weighing the risk of trial participation on patient safety. As Teresa and I are well aware, in careers that bridge research and clinical work, these challenges are particularly severe in the emergency department, where patient arrivals cannot be restricted based on available resources.
Our objective was to figure out how to safely enroll participants in a clinical trial despite the COVID-19 pandemic, which exacerbated the nursing shortage and created a roller coaster of patient volumes. All of this without impacting the standard of care, which must be maintained for all emergency department patients.
Our project started as a pragmatic plan to address these challenges and evolved into a structured approach to develop strategies. We debriefed following every enrollment for a phase 1 study for sickle cell patients experiencing vaso-occlusive crisis. That was between May 2021 and February of this year. Teresa Schultz and Teresa Weber played a major role in each of these debriefs, discussing the enrollment with the clinical nursing team to uncover subtle problems that the bedside nurse might not mention to the research investigators such as myself because of the can-do emergency room attitude. We then piloted an open-ended survey among research and nursing leadership from the emergency and hematology divisions. The final survey will be distributed to all research team staff and clinical ED staff involved in patient enrollments. Responses to pilot surveys were reviewed and coded by myself and 2 other collaborators. By consensus, we organized responses into distinct themes and categorized each theme as a factor existing prior to the pandemic or as a new strategy developed during the pandemic-related healthcare crisis.
In the end, we were able to enroll 25 patients and complete a phase 1 clinical trial in the emergency department during the ongoing healthcare crisis. From our pilot surveys, 7 new factors were identified, as well as 5 foundational elements that support safe clinical trial enrollment during a healthcare crisis. While we wait for the formal survey results, we want to highlight 3 new strategies and 1 foundational element that came through loud and clear in our initial analysis. We implemented a new strategy of closed loop communication via text or phone between the clinical research team and nursing leadership prior to every enrollment. Our nursing director and nursing leadership team triage the enrollment requests 24/7. In the emergency department, we always figure out a way to push forward, and it was really important to keep nursing workload in mind.
I'd like to mention 2 other new strategies, which I witnessed as the trial developed and were mentioned in initial survey responses. To accomplish our mission of continuing research for the future without risking standard clinical work, we built out supports never seen in the ED before. This study required frequent lab draws, vitals, and an infusion. One strategy, developed by Teresa Weber, was training study staff to print research lab slips to decrease the risk of mislabeled samples. Another strategy involved bringing in a research nurse to program the infusion pump, while the bedside nurse maintained the standard of care.
I also want to highlight the long-term research infrastructure in the emergency department, which we identified as a critical foundational element. We rely on dedicated full-time research staff for any clinical trial enrollments in the busy emergency department. This foundation, together with our team effort, brought collaboration to the next level, and it allowed us to complete this phase 1 clinical trial, overcoming huge obstacles. Importantly, based on my post-enrollment debriefs, there were no adverse impacts to the general emergency department population.
The analysis of the primary outcomes for the phase 1 clinical trial will be described elsewhere. Teresa and I are both very grateful that we could participate in the effort to enroll patients for this trial. Much of the basic science and initial pilot work for the study drug were done by researchers now here at Children's National. Marshall Sommer and Sevi Majumdar have been great mentors for me in this project and huge advocates of new drug development for children with sickle cell disease. The pharmaceutical sponsor has also been exceptionally flexible in helping us pivot to create new strategies when enrollment stalled. In fact, while Teresa and I are at the face of success today, we've had the chance to work with many other partners at Children's National who are integral to successful enrollments. I'm so thankful for the dedication of the hematology faculty and research staff, the experience of our own ED clinical research team, the clinical laboratory for taking on additional workload during a busy time, and the help from nursing and other divisions, such as the clinical trials unit. Lastly, many thanks to nursing research leadership at the hospital for fostering an environment that celebrates partnerships, such as the one that Teresa and I discussed today.
Hi, my name is Amy Liliastrand, and I work at Children's National in the Department of Nursing Science, Professional Practice, and Quality as a Senior Nursing Quality Outcomes Coordinator. I most recently was a clinical nurse at the Children's National Montgomery County Regional Outpatient Center in Rockville. And previous to that, I was a nurse on 7 East since 2015. I'm a certified pediatric nurse and recently graduated with my MSN in Patient Safety and Quality. This quality improvement project was the capstone experience portion of my MSN that I completed with the nurses and techs in the clinics at the Montgomery County Regional Outpatient Center. I'd like to thank my mentor during this capstone experience, Pam Kine, and the site clinical manager, Tiffany Lowe, for their support and welcoming of the project. My project is entitled Improving Pediatric Transgender Patient Nursing Care. The main message of this project is that education, mentoring, and process change tailored to the specific unit and to individual staff improve staff knowledge and observe gender-affirming care practices. The background in the literature described in more detail in the poster supports the need for education and process change for provision of gender-affirming care. Additionally, nursing staff reported experiences and patient and parent feedback in the clinic supported the need for this project. The objectives were to increase nursing staff knowledge about relevant pediatric transgender patient health inequities and associated nursing care needs and process changes with a long-term goal of improving transgender patient experiences and outcomes. The methods consisted of standard QI methods and PDSA cycles with a pre-test, interventions, and then a post-test. As a note, participation was voluntary and involved 19 staff, which comprised 86% of the clinical staff at MC Rock. And these were nurses, RNs, LPNs, and techs, med techs, and PCTs. The process involved first a knowledge-based pretest. Then I conducted 1 hour small group in-person interactive education sessions using a slide presentation, handouts, and discussion and questions. Distribution of optional pronoun pins to wear on staff badges or on scrubs. You can see these pronoun pins in the photo on the poster. 2 to 3 weeks of one-on-one mentoring and support in handling any challenges that came up for staff and in implementing practice changes, such as calling patients by the last name from the waiting area to avoid outing a patient in the entire waiting area, asking for and using a patient's preferred name and pronouns, such as he, she, they, or avoiding the use of pronouns altogether and instead using the patient's preferred name, and communication and documentation of the patient's preferred name and pronoun for use by the patient's care team. I organized a fun educational Pride Day celebration with themed food and educational trivia style questions, as you can see in the photo on the poster, for additional education and awareness that reached providers and front desk staff. And lastly, I administered a post-test for measurement of change in knowledge. In comparing the pre-test and post-test scores, a significant improvement was seen among all staff. The post-test scores increased 31% compared to pre-test scores. The pre-test mean score was 58.7%, which increased to 89.5% on the post-test. And as you can see in the graph of the pre and post-test scores broken down by individual question, there was great improvement in scores on each question, except question 6, which was an area of strength for participants from the beginning. My observations in conducting this project included the identification of broad staff misunderstanding and misinformation that became apparent through discussions and questions during the education sessions. I observed staff using last name in waiting areas and an increased sensitivity to pronoun use. Leadership, clinical, and ancillary staff requested education. Staff were engaged, asked questions, participated in discussions, and had suggestions for process improvements. And there was positive staff feedback regarding the education and practice using a variety of pronouns, and some patients and parents commented positively about staff wearing pronoun pins. The next steps, which have been started or are a work in progress at Children's National, include hospital-sponsored pronoun pins, continued staff and provider education, medical record updates, including printed information, such as the face sheet used to call a patient from the waiting area, need to include preferred name and pronoun, the inclusion of pronouns in staff email signatures, development of a hospital-sponsored visual guideline for staff reference as a resource to support staff in gender-affirming interactions, monitoring and reinforcement of gender-affirming care competence, and creating a commitment to families to provide exemplary gender-affirming care. Thank you.
Hello, everyone. Thank you for listening to our presentation for this year's Research, Education, and Innovation Week. My name is Michael Ruiz, and I am the Patient Care Quality and Research Data Analyst for the Nursing Science Professional Practice and Quality Department. I'd like to introduce the other members of the abstract team, Raven McLeese and Craig Roberson. Our project was truly a team effort, each member bringing their own expertise to our intervention. So our abstract is called Show Me the Data, Ensuring Quality, Maintaining Sustainability, and Growing Confidence in RN Data Interpretation. I found a great quality quote for our initiative from Peter Drucker that says, "What gets measured gets improved." So let me take you back to 2020. In 2020, the Nursing Quality team attended all the system-level Shared Nursing Leadership Quality and Research Council meetings. These meetings are one place the unit-specific Culture of Nursing Excellent teams, or CONE teams, present their annual CONE reports. When it comes to the CONE reports, they are created with a particular structure in mind, while displaying the unit's most recent benchmark data and current interventions. These reports are centered around unit-specific nurse-sensitive indicators, such as patient experience, clinical indicators, and RN satisfaction. Each report is supposed to have all of these items. So in 2020, as the team listened to CONE presentations, the team observed inconsistencies in the unit's CONE reports and interpretation. 58% of the CONE reports had missing content, and only 17 of the reports had the unit's most recent and accurate data. The nursing quality team saw this problem as an opportunity to engage with the unit CONE teams while attempting to enhance the quality of the CONE reports. Nursing quality team dedicated time to provide additional support. The team created a main goal to assist the units with reviewing their CONE reports for missing content, inaccurate data, and assist with interpretation. Secondary goals were to help CONE teams gain confidence in data interpretation and inform the units about trends, patterns of excellence, as well as needs for improvement when it comes to the unit's NSIs. So in 2021, the nursing quality team launched an initiative called Show Me the Data. The team followed the quality and research report out schedule and reached out to the cone team scheduled to present at QNR each month. Each month, the nursing quality team held a planning meeting with each other to discuss topics for discussion and areas of focus. The cone teams were asked to send a copy of their most recent cone reports for review. The nursing quality team then reviewed the report at the planning meeting, and after the planning was completed, a Show Me the Data meeting was scheduled with the unit cone team. During the Show Me the Data meetings, the nursing quality team identified any gaps in the unit cone report in terms of content and provided any data that was missing. In addition, the units took the opportunity to discuss their data in depth. Data interpretation was a common ask from the units, especially when it came to interpretation of RN satisfaction data reports. In addition, the nursing quality team was able to help maintain sustainability of the cone reports by helping some units complete portions of their cone reports during times of high census or low staffing during the height of the pandemic. We believe that the Show Me the Data initiative was a success. By the end of 2021, the nursing quality team was able to engage with all unit cone teams. The unit cone reports went from 42% of reports having all required content in 2020 to 100% having all required content in 2021. The cone reports went from 17% with accurate data for all of their indicators in 2020 to 83% with accurate data in 2021. Cone teams were verbally expressed appreciation for assistance in data interpretation and felt more confident after talking to the team. Well, this was our lightning presentation. We thank you for taking your time to listen, and we hope you have a great research, education, and innovation week. If you have any questions about our intervention, feel free to reach out. Thanks again.
Hi, I'm Claire Bogard, and I'm here to present the COVID-19 vaccine program design and implementation on academic children's hospitals model, approach, and outcomes. This is a work that was authored by these leaders here on this screen, but we want to give a big thanks and acknowledgement to the many other leaders here at Children's National and throughout the community, and all of the staff that helped contribute to vaccinating patients and families here in our area. Our objective was to create a multidisciplinary, community-focused strategy to efficiently, expeditiously, and equitably vaccinate the children in our community with the COVID-19 vaccine. This required collaboration, not only within departments here at Children's National Hospital, but also with community. And that helped us build a dynamic program that began as this large volume centralized vaccine clinics and then expanded to smaller volume integrated vaccine clinics in specialty care and primary care. We worked a lot on patient outreach. We wanted to be able to prioritize patients based on health condition and priority risk neighborhood to the access points that we had here at the hospital. We also wanted to get information to every parent who is looking to Children's National for information on the vaccine safety, efficacy, and accessibility of the vaccine. Access was an important part that has changed throughout this last year. And what our goal was to do was to get it into the arms of as many patients that wanted it. So we always kept equity as a focus, keeping our prioritization on those with highest risk to getting the infection itself. But we worked with our partners to be able to give it to inpatients here at Children's National and our HSC Pediatric Center, to eligible ambulatory patients at select specialty clinics, at centralized vaccine-only clinics at different locations throughout the region, all of our primary care locations, our school-based health centers, and on our mobile unit. We also had a great program with the ABC consult team and our nurse navigator program that were able to get vaccines in arms of patients with special needs. And we also worked with our allergists to help develop a program where we could safely administer the vaccine to those that were at risk of more serious adverse reaction. Logistically, this required a lot of coordination. We made a lot of efforts to make sure that we fully vaccinated each individual that we started the vaccine process on, that we minimized our dose variance or waste, and that we were able to do secure reporting to all of the local health registries. We're very proud of our results. When we look at the amount of patients we were able to vaccinate from January through November, we are happy to say that we vaccinated thousands, tens of thousands. 97% of individuals who received dose 1 through our program actually returned for dose 2. And of those vaccinated, about a quarter were between ages 5 and 11, which is great because they have the lowest access in the community. 68% were the older group of kids, 12 to 24. We were able to reach 2/3 of the people that we vaccinated were from high-risk neighborhoods, and close to 60% were Black or African American, and close to 15% were Hispanic, which exceed the proportions of those communities in our local population, which helps us feel good that our equitable strategy reached the people highest in need. With that being said, however, our vaccine efforts reached as many people as we could in our community, and we're proud to have played a big part in our community's response. But we still have a ways to go with reaching communities that are more hesitant and those that are higher risk of getting poor infections. Thank you.
Hi, my name is Maria Gracia Rivas Perrier, and I'm a music therapist here at Children's National in the Center for Cancer and Blood Disorders. I'm also the lead researcher for the first music therapy study here at the hospital. Other research team members also include Dr. Anthony Meadows from Shenandoah University, Dr. Bost, Stephanie Margiles, Brenda Martin, Brittany Moffett, and Dr. Speller Brown from Children's National. This research was focused on measuring the impact of a single music therapy session on the pain perception and emotional well-being of patients with sickle cell disease. Sickle cell disease is a common genetic condition in the United States, and one of the most common symptoms are severe pain crises known as vaso-occlusive crises, and one of the main reasons why patients get admitted to the hospital. In addition to the stigma that comes with this invisible disease and the psychosocial and physical stressors, the patients also have limited treatment options, and because of these things and the increased deaths linked to opioid prescriptions, there's an interest in non-pharmacological treatments for pain. Now, most people are familiar with the gate control theory by Melsack, but he later proposed an updated theory called the neuromatrix theory of pain, where he recognized that the cognitive and affective components of a person's lived experience directly affects one's pain perception and relief, meaning both have sensory, cognitive, and emotion-related components. Music therapy, which is the clinical and evidence-based use of music to reach an individualized goal, has been shown to be an effective therapy in addressing not just pain, but its multidimensional experience. In our study, we utilized the convergent mixed methods design and measured pre, during, and post scores using a visual analog scale. The music therapy sessions were facilitated by me, a board-certified music therapist, and I invited patients to name their pain and communicate with it within a specific music structure and singing intervention. Then we transitioned using new music and a breathing technique, which incorporated inhalation through the nose and exhalation while creating a sound and visualizing pain leaving their body. The second part is visualizing and singing what their life would look like without this pain using present tense vocabulary. The whole time I encourage patients to directly engage with their body instead of distract away from it. After the sessions, patients were able to verbally process with me and also later interviewed by our social worker. Through the Wilkinson sign rank test, we found a significant change in the patient's pain perception after the intervention. Patients reported a 3.03 point difference when comparing the pre-music therapy pain and their pain during the music therapy intervention. So 75% found at least 2-point reduction, and 100% of them reported some reduction. When comparing pre-intervention and post-intervention scores, 76% of the patients reported pain decrease. But when comparing pain scores of the pain perception during the intervention and afterwards, some patients reported an increase of 1.14 and 33% of participants reported a decrease. This really highlights the impact of the singing music therapy intervention and direct engagement with one's pain and body. Now, all of the sessions and interviews were transcribed, coded, and analyzed, and we found 5 emergent themes: decreased pain perception, increased insight, openness to verbal engagement, improved mood, and expressive freedom. In our manuscript, we go into more detail for all of these, but I wanted to highlight some of the quotes shared by the patients. For pain perception, one shared, "For just a little moment, I felt like I didn't have any more pain, like I didn't have sickle cell anymore." Patients also shared that they found insight within their sickle cell. And one shared, "I typically shut my pain out. That was the first time I actually acknowledged it. The pain was just an accumulation of emotional pain, mostly, that came primarily from my parents." We also found that patients were more likely to verbally engage after engaging in a music therapy session. One shared, "I usually don't share things like that, so this was different for me." We also found improved mood. One shared, "When I'm in the hospital, I get depressed, so the music therapy session made me have a fun time." And last but not least, expressive freedom. One shared, "I was able to express who I was freely and without feeling judged. I was able to express it through music, one of my favorite ways to express my feelings." Now, the findings from this study suggest music therapy is effective in reducing reported pain, simultaneously addressing cognitive and affective components of the pain experience consistent with the neuromatrix theory of pain. This also demonstrates the need for addressing the multidimensionality of the pain experience and the need to integrate music therapy into the standard care for VOC pain, or vaso-occlusive crisis pain. Thank you.
Hello, and welcome to our online presentation, Calculating Success, Improving Safety with an Online Insulin Bolus Calculator. My name is Laura Welch, and I am the Senior Clinical Outcomes Coordinator, SKIN Team Lead, under the Department of Nursing Quality.
And I'm Jennifer Duval, the Professional Practice Specialist on 7 East. We'd like to take this moment to acknowledge our 7 East Medical Care Unit and IRU educators and staff nurses for trialing this process, Cerner and the Nursing IT Department for helping with the build of our project, and endocrine physicians for their project oversight.
The process for ensuring safe insulin delivery to patients can be confusing and time-consuming. Lack of standardization in insulin calculation practices, gaps in education, and inconsistent witnessing processes led to multiple insulin safety errors and was a burden on nursing workflow. Our objective was to improve insulin safety and nursing workflow by implementing an online bolus insulin calculator for use in the inpatient and perioperative areas. This online tool will replace the cumbersome paper-based processes and automatically calculate insulin bolus doses.
Here is what the old paper-based form looks like. You are not expected to read it on this slide, but the intention is to show you that it is visually busy with multiple lines to complete and required nurses to manually perform math calculations. 2 RNs would each have to complete a sheet independently and compare them. Storage was done in the high-risk binders in the medication room. In comparison, on the right is the new online insulin calculation form. This tool automatically completes calculations from information that has been entered into the fields by the nurses. Each RN completes an online form, and then a comparison of the forms is done. The results are saved electronically in the patient's chart, eliminating the need for paper.
We were able to demonstrate an organizational improvement in safety by looking at incident reports, which showed a 10-time reduction in calculation and dosing errors. The implementation of an online insulin bolus dose calculator eased nursing workflow. Time trials concluded that the online process was an average of 3.2 minutes faster than the previous paper-based process. The graph shows results from our post-implementation survey for inpatient nurses that was completed 6 months after go live in July of 2021. These results showed that 96% of the nurses preferred the use of the online calculator. 100% of the nurses found that it was easier to use. 99% of the nurses thought the process was now faster, and 97% thought that giving insulin in this manner was now safer compared to the old paper-based processes.
Hello, my name is Katie Dunn. I'm one of the nurse practitioners in the Division of Urology at Children's National. Also included in my abstract team is Dr. Hans Pohl, Chief of the Division of Urology. In entering this specialty as a new nurse practitioner, I realized there was a lot to learn and craved guidance. This inspired Dr. Pohl and I to create an organized, evidence-based orientation program for pediatric urology advanced practice providers, or APPs. We hope that this will not only benefit Children's National, but also serve as a model for institutions nationwide. The purpose of this project is to guide development of an evidence-based curriculum that meets the critical educational needs of pediatric urology subspecialty training of advanced practice providers. Building upon our pediatric urology APP orientation program at Children's will ease the transition between student and first provider role, leading to increased knowledge, confidence, and productivity. This will contribute to the ultimate goal of improved patient care and satisfaction. For our method, an anonymous survey was sent to the 331 members of the Pediatric Urology Nurses and Specialists, or PUNS, professional organization, to assess the qualities of orientation and training of pediatric urology APPs at institutions across the nation. The survey included quantitative demographic information as well as the opportunity for qualitative free response reflecting on the APP's specific orientation positives and negatives. Prior to distribution, this survey was reviewed and approved by the Nursing Research Advisory Committee and Institutional Review Board at Children's National. Descriptive statistics were used to characterize the results of the survey by this group of participants. For our results, a total of 49 participants submitted the survey. Most participants reported completion of a 1 to 3 month orientation program that was moderately structured. A moderately structured program was defined as having some resources provided and a general schedule. The overall mean self-rating of preparedness was a 6.2 out of 10 at the conclusion of their training. However, this rating varied between participants that had training programs under and over 3 months duration. While demographic variables such as years of experience and practice type were considered, the only significant finding was length of orientation. In conclusion, most pediatric urology APPs feel they were not optimally prepared upon entering the field. Our survey results show that longer training programs, at least 3 months, lead to higher levels of self-assuredness. Along with the results of our survey, we also aim to model our orientation program on the educational philosophy of mastery learning. Mastery learning emphasizes achieving a level of proficiency in one subject prior to progressing to the next level. It focuses on providing sufficient time for the student to learn successfully. The Pediatric Urology APP orientation program at Children's will be adjusted to align with this teaching strategy by meeting the concerns of survey participants. This will ensure a more equipped team of advanced practice providers. Thank you for inviting me to discuss this project as a NurseCast during REI Week 2022.